All right, I'd like everyone to please take their seats. We're going to start one of our scientific sessions. In this room, we will have our scientific session on trauma. Concurrently, we have two other scientific sessions. So if you're interested in the scientific session on CDH and ECMO, that is in Gran Saguaro East. And if you're interested in the scientific session on practice and innovation, that is in Gran Saguaro West. But we really hope you'll stay here for our fantastic scientific session on trauma. I'd like to introduce our moderators for the session. Dr. Kim Wallenstein is an assistant professor of surgery and pediatric trauma medical director at SUNY Upstate Medical University. And Dr. Michael Dingledine is an associate professor of surgery at Rainbow Babies and Children's Hospital at Case Western Reserve University. And our chat moderator for this session is Dr. Suhail Zunaidin, a general surgery resident at Lurie Children's Hospital in Chicago.
Thank you. All right. Thank you, Dr. Henry. Our first talk is Enhancing Pediatric Traumatic Brain Injury Outcomes, Evaluating the Benefits of Ventriculostomy Compared to Intracranial Pressure Monitoring Alone, by Dr. Padwardhan.
Good morning. My name's Utsav Patwardhan, and I'm a research resident at Rady Children's Hospital, San Diego. Thank you for the privilege of the podium. We have some disclosures, but none related to this talk. Following severe TBI, patients may undergo placement of an intracranial pressure monitor with or without ventriculostomy. The decision whether to place or drain can be very surgeon-dependent, with concerns about potential infectious risks, CSF leak, or hemorrhage. There is also significant disagreement between existing guidelines and recent literature. The Brain Trauma Foundation provides a grade 3 recommendation for CSF drainage. However, the ADAPT trial in 2019 showed that drainage did not provide any long-term improvement. Given this discordance, we sought to use a large national database to compare outcomes. We used TQIP data to identify children presenting with severe, blunt TBI from 2016 to 2021 that underwent placement of an ICP monitor with or without ventriculostomy. Patients were excluded if they had a penetrating injury or open fracture. Patients who died or underwent a craniectomy within 48 hours of arrival were also excluded. Our primary outcome was discharge disposition as a surrogate for functional status and mortality. Secondary outcomes were length of stay and infectious complications. Of 1,719 patients included in the study, 66% were male and 54% had ventriculostomy placement. Between the ICP and drain groups, there were no differences in mean age or sex. Trauma center type was correlated with ventriculostomy use. Standalone pediatric centers were less likely to use a drain compared to joint level 1 pediatric and adult centers. When we compared patients between both groups, patients with a ventriculostomy were more likely to have a fall or assault mechanism. GCS and ISS did not vary, but drain patients had a slightly higher mean AIS. Although a drain was not protective against needing subsequent surgery, it was associated with increased time to surgery. Ventriculostomy patients had more ventilator days, ICU days, and a higher median length of stay. Finally, on univariate analysis, there was no difference across all discharge disposition categories, including mortality. This figure shows a competing risk regression model for two outcomes, odds of discharge to rehab on the left and death on the right, compared to discharge home. The base model starts with ventriculostomy alone, and then each model adds one new variable to the model. Model 1 adjusts for head AIS, Model 2 adds age, then mechanism injury, infectious complications, and finally craniectomy. As you can see, although there was no association with death, drain placement was a strong, independent predictor of discharge to home, even after controlling for multiple variables, a key finding that contrasts with existing literature. As with any studies using an administrative database, we had limited access to granular data, especially for factors that would have influenced the choice of intervention, such as imaging results or exam. We also only know if a drain was placed, not how much CSF was actually drained. This limits our ability to make definitive recommendations. In conclusion, we found that ventriculostomy was used more in joint adult and pediatric trauma centers, but much less at standalone children's hospitals. Notably, the patients at the ped centers were significantly younger and had a slightly higher median AIS head. Drain use was also more common for fall or assault and in patients with higher severity. Ventriculostomy was not protective against ventriculostomy, however, was not protective against neurosurgery. However, among those that got a craniectomy, the drain patients underwent surgery later. Ultimately, drains were associated with greater discharge to home on multivariate analysis, emphasizing its potential role for the management of severe TBI. Although length of stay and ICU days were higher, drain patients did not have more infectious complications. This contrasts with some of the existing literature and supports the existing Brain Trauma Foundation guidelines. Our next study is identifying which patients can benefit the most from ventriculostomy placement, given the wide variety in practice patterns. This will help establish more pediatric-specific guidelines and improve overall outcomes. Thank you very much for your time. I'd like to acknowledge the support of my mentor, Dr. Ignacio, and our collaborators at Scripps Mercy Hospital.
Great, thank you. Dr. Russell.
Utsav, great job. Thank you so much for that presentation. Maybe I'm being dense, but I'm just curious, why did you choose to exclude kids with open fractures?
So our concern with kids with any sort of significant skull fracture basically is no longer a closed system. It's hard from TQIP to get a sense of how severe these open fractures were. So we wanted to take it out because essentially with controlling pressure, since it's an open system, it kind of affects the decision making. So that was our way to kind of simplify the variables. Thank you for your patience.
Our next talk is a statewide retrospective analysis of rural versus urban pediatric trauma recidivism, presented by Matthew Price.
Good morning. Thank you for the opportunity to present today. The reason I did this project is I'm very interested in patterns of injury and patterns of re-injury, as those are very important in planning targeted intervention efforts. I'm going to start by giving a little background on the state of Maryland. In Maryland, there's a population of 6.2 million people with 24 counties, 18 of which are rural. There's a single pediatric trauma center in Baltimore City, then another pediatric trauma center down in DC. 25% of the population in Maryland live in rural counties. And the definition for rural, per the Annotated Code of Maryland, is geographic isolation, lack of transportation, and lack of access to and availability of healthcare. For our study, we aim to compare patterns of re-injury in rural and urban settings, with our data source being the Maryland Health Services Cost Review Commission. This is a really robust data set that allows us to track patients despite which hospital they go to. They can go to the University of Maryland, they can go to Johns Hopkins, and we're able to identify that it's the same patient. Our study population were pediatric patients who presented to any emergency department in Maryland with a traumatic injury over a 6-year time period, with our primary outcome being re-injury. Our definition of re-injury is repeat presentation for a new traumatic injury within 1 year of their initial injury. And we looked at a secondary outcome of major re-injury defined as requiring an inpatient admission for treatment. Our analyses were univariable, multivariable logistic regression, as well as a multi-level model to explore the county-level heterogeneity for the odds of re-injury. Both the multivariable and multi-level models were adjusted for demographics, index injury mechanism, intent, and severity. So looking at injury and re-injury in Maryland, over the study period, there were 387,000 index presentations to emergency department for a traumatic injury. Of these, 66% were in urban areas. And when we look at re-injury, we actually see in rural areas there was a higher proportion who re-presented within a year for a second injury. And on our adjusted model, we see that rural areas had a higher increased odds for re-injury. This is our multi-level model. I'm going to take a moment to explain what we're looking at here. The red line is indicating, or the red line right in the middle is indicating the average risk for re-injury across the state. Each dot represents a county, and from left to right, we have them from the least population dense county to the highest population dense county. And what we see is the adjusted relative risk for re-injury by each county. We see the more rural counties tend to be having higher risks for re-injury. And as you go to the right to the more urban counties, there's a lower risk for re-injury. Of the blue line there is identifying the state definition for urban and rural. The outlier for the urban counties with a higher risk is Baltimore City. Looking at our major re-injury or inpatient admission, there were 17,000 initial traumatic injuries that required inpatient admission over the study period. Of these, 72% were in urban areas. And as far as proportions, there was no significant difference between re-injury, between rural and urban settings. On our adjusted model, we also did not reach significance for a difference between rural and urban. So in conclusion, there is an increased adjusted odds for re-injury among pediatric patients who present to an emergency department in the state of Maryland. The increased risk for re-injury in rural patients is attenuated when examining major re-injury, and these findings tend to suggest that the risk for pediatric re-injury in rural settings is largely explained by presentations for the treatment of relatively minor injuries, which makes it so further studies are needed to determine, is this simply a lack of access to primary care providers in rural settings and they're presenting to emergency departments, or if there really is a really increased risk for re-injury. Grateful for our study team and the financial support during my research years and the Johns Hopkins Surgery Center for Outcomes Research who helped us get access to the data set. Thank you.
This talk is open for questions.
Remy Ignacio, San Diego. I think this is a really good study in the sense that this is the population that has the most difficult access, right? So you're in a rural area, and I think about all the stuff that Dr. Russell has done. And so moving forward, what changes are you going to make with this data? And two, with all the work that's being done with pediatric readiness, how do you get to the fine details of what those centers need that are in those rural areas? Great presentation.
Yeah, thank you for the question. Right now, what we're trying to do as part of this project is we're gaining access to the outpatient data of the HSCRC. We don't have access to that yet, but there is a component that we're able to actually see primary care provider visits. So that's to bring us to trying to understand, is this really related to lack of access to primary care providers in rural settings? And if so, then obviously we need to do more targeted efforts, so education as to where patients can go rather than having presentations to the emergency department. Thank you.
Thank you.
Oh.
Our next talk is variable impact of the APSA solid organ injury guidelines, declining splenectomy rates in pediatric trauma centers, countered by rising splenectomy rates in adult trauma centers and injured adolescents, by Dr. Shaidak from Johns Hopkins.
Good morning, everyone, and thank you for the opportunity to present our work. We have no disclosures. So blunt solid organ injury in children is ideally treated with non-operative management, which has proven to be successful for many patients. Indeed, the APSA solid organ injury guideline recommend first transfusing the patient with or without embolization before going to any operative management. And they only recommend operative exploration with control of bleeding when the vitals are unstable despite red blood cell transfusion, in which case we can also think about massive transfusion protocols. A lot of studies has been done comparing adult trauma centers and pediatric trauma centers and found that there's a higher splenectomy rate in adult trauma centers. Therefore, the aim of our study was to assess the rates of splenectomy in children after blunt splenic injury across different age groups, as well as different types of trauma centers. And we also aim to analyze the trends of splenectomies rate over time. We hypothesized that adult trauma centers would be performing more splenectomy, regardless of age. And we also hypothesized that splenectomy rates would be declining as non-operative management became more widely accepted for injured children. In order to do that, we conducted a retrospective review using the National Trauma Data Bank from 2010 to 2018. Children 17 years and under with blunt splenic injury were included. Our primary variable of interest was ACS and state-designated trauma center types. We divided into pediatric trauma centers, adult trauma centers, and mixed trauma centers. Our outcome of interest was the splenectomy rate, stratified by age, year, and trauma center type. We used descriptive analysis as well as multivariable logistic regressions to conduct our analysis. So we ended up with 12,843 patients, 25% of which were treated at pediatric trauma centers, 40% at adult trauma centers, and 35% at mixed trauma centers. Not surprisingly, patients treated at adult trauma centers were older than those treated at pediatric trauma centers, and therefore had a higher weight. There was no difference in sex and injury severity score. Interestingly, white patients were more likely to be treated at adult trauma centers, while black patients were more likely to be treated at pediatric trauma centers. Here we can see the outcomes, that's splenectomy. And we can see that at adult trauma centers, the rate of splenectomy is a very high 8.1% compared to a 5.9% at mixed trauma centers and only 1.9% at pediatric trauma centers. And this was statistically significant. On multivariable logistic regression, we found that being treated at mixed trauma centers and adult trauma centers increases the risk of undergoing splenectomy by 230% compared to pediatric trauma centers. In this graph here, you can see the percentage of splenectomy stratified by age at different trauma centers. On the x-axis, you can see the age, and on the y-axis, the percentage. Regardless of age, you can see that the blue line, the pediatric trauma centers, the rate of splenectomy was almost always around 2%. However, in adult trauma centers and mixed trauma centers, you can first notice that the rate of splenectomy is higher at almost all the age groups. And this was more prominent in older age group, especially 13 to 17. Here we conducted a multivariable logistic regression accounting for injury severity score and sex for each age group. And we compared the odds of undergoing splenectomy at adult trauma centers and mixed trauma centers compared to the pediatric trauma centers. So the horizontal line is the reference, which is the pediatric trauma center. And the first thing that you can notice is that most of these dots are above this reference line, which indicates that there's an increased risk of splenectomy in adult trauma centers and mixed trauma centers compared to pediatric trauma centers. And again, this was more prominent in ages 13 to 17, as indicated by the asterisks. We can also see by the dotted colored line that there's an increased trend, and this indicates that as age increases, the odds of splenectomy also increases in both adult trauma centers and mixed trauma centers. Finally, we looked at the trend of splenectomy over the years at different trauma centers, and we can see that there's a slight increase in splenectomy rates in adult trauma centers and a slight decrease from 3% in 2010 to 2% in 2018 in pediatric trauma centers. However, all these were not statistically significant. In conclusion, splenic salvage rates after blunt splenic injury are better at pediatric trauma centers compared to mixed trauma centers and adult trauma centers, especially for adolescents between 13 to 17. The APSA solid organ injury guideline may be the driving factor for this decline in splenectomies, especially in pediatric centers. And we can still see that there's rising splenectomy rates in adult trauma centers. This urges the need for education efforts and state trauma guidelines and policy in order to decrease splenectomy rates at adult trauma centers. Thank you very much, and I'll be happy to take any question.
Thank you, excellent study. Open for questions now. Dr. Stylianos.
Yeah, hi, Steve Stylianos from New York. Thanks for presenting that. And I would be optimistic in a way because under the age of 13, the graph lines were narrowing. They were quite narrow. And so I think the message is getting out. In the teenage years, we haven't gotten there yet. We haven't tackled that one yet. But one of the things that you've shown is that if there isn't a pediatric surgeon around to go to conference, to go to trauma peer review, et cetera, it's not going to work as well. But there aren't enough of us who either care about trauma or are geographically there. So perhaps virtual agreements or virtual communication with pediatric surgeons for our adult trauma colleagues might be helpful. I wonder if you could comment on what the impact of a pediatric surgeon being somewhere on that team might have. Thanks.
Thank you very much for your comment. And I agree that our findings were nice, especially for the young age, and the main problem would be for adolescents after 13 to 18. So one of the things that you said is the scarcity of pediatric surgeons and the scarcity of trauma pediatric surgeons. I think that having a pediatric surgeon, at least in the hospital or around or present virtually, a pediatric surgeon specialized in trauma that definitely knows the guideline, especially the APSA, blunt splanchnic injury guidelines, would help decrease these splenectomy rates and advise adult trauma surgeons into choosing the right procedures and the right move forward for patients with splenic injury. Thank you very much.
Our next talk will be high-volume pediatric trauma centers are associated with improved mortality in severe pediatric TBI. The talk will be presented by Dr. Andrena Giron from Children's Hospital, Orange County.
Thank you for the opportunity to share our work today. I have no disclosures. Why study severe pediatric traumatic brain injury? It is a common healthcare problem in children, and it can carry a high mortality rate, in some instances up to 40%. Our group did a previous study where we wanted to look at the variations in mortality in severe traumatic brain injury depending on which center patients were being treated at. In this graph, each bar represents a center. And we can see that some centers are doing better compared to others. We also see that some of these bars are really wide. And one reason for this could be related to hospital volume. So thinking of this, we conducted a follow-up study. And our hypothesis was, does the total pediatric traumatic brain injury volume of a center correlate with severe traumatic brain injury survival? We used data from the National Trauma Data Bank, years 2017 to 2019. We included all patients below the age of 18 with severe traumatic brain injury, which we classified as a GCS score below 8. Our exposure variable was total center traumatic brain injury volume. Our outcome was mortality. And we conducted a retrospective cohort analysis using both descriptive statistics and multivariate logistic regressions. In the first part of our analysis, we took all 695 centers, and we needed to classify them into high versus low. So we look at the total distribution, and the median of that total distribution was 18.3 cases per year. So taking this number, we classify centers into high. 52 centers had more than 18.3 cases per year, so they were in the high category. Everybody else was in the low volume category. When conducting the descriptive statistics, comparing both low volume centers versus high volume centers, we found that low volume centers had a mortality of almost 26% versus 23% in high volume centers. This is a small difference, however, still statistically significant. The rest of the variables in this graph were those that we found to be statistically significant differences. Next, we conducted a logistic regression analysis in order to adjust for risk. We adjusted for age, race, ethnicity, sex, as well as injury severity score. And we found that low volume centers that treated less than 18.3 cases per year had an odds ratio of 1.06. So they were associated with increased mortality. Next, we wanted to pinpoint exactly where in our volume distribution we had the highest association with improved mortality. So we took our 695 centers, and this time we classify them into tertiles. Those with more than 58 cases during our study period were classified as high. Those between 25 and 58 cases during our study period were classified as medium, and any of the centers with less than 25 cases were classified as low. We conducted a logistic regression analysis, and we found that it was the highest tertile with an odds ratio of 0.97 that actually had less mortality compared to everybody else. Our limitations are inherent to the retrospective study design, the use of a large data bank with a lot of missingness, as well as lack of granular data and lack of long-term outcomes. And going back to our original point, where we look at this graph with really wide standard error bars that could be related to volume and or original hypothesis that it might be related to volume, we found that indeed the total pediatric traumatic brain injury volume of a center is associated with severe traumatic brain injury mortality. That low volume is associated with increased severe traumatic brain injury mortality, whereas patients treated at highest volume centers had the lowest odds of mortality. Thank you. I'll be happy to take any questions.
Open for questions.
Hello, my name is Charissa. I'm a research fellow at Lurie. I was wondering, in your logistic regression models, were you able to control for injury severity in addition to TBI? Because I wonder at those high volume trauma centers if they got sicker patients, which would be more, it would be really interesting to see if you still saw that effect.
Yes, correct. We did adjust for injury severity score in all of them.
Any other questions? Just one quick question.
Yes.
Your data kind of suggests that we should be transferring these patients to higher volume centers that have decreased mortality, but then we also know that proper and timely treatment is also pretty critical. So were you able to tell how many of these patients were transfers in or had to be transferred out?
We did not look at that, but that would be a really good follow-up study. Maybe I'll come back and present that next year.
Thank you.
Great.
Thank you.
Thank you. Our next talk is the workup and management of pneumomediastinum and isolated blunt pediatric trauma by Dr. Heather Hartman from the University of Michigan.
All right. Thank you for allowing me to present today. There's no consensus on the evaluation and management of isolated pneumomediastinum after blunt trauma in children. While the course is generally benign, esophageal injury is a much feared complication, often prompting a more aggressive evaluation and management that involves multiple imaging studies. So pneumomediastinum is a rare condition that generally presents with chest and neck pain that's due to closed pressure against a glottis or a Valsalva maneuver. Associated events often include asthma exacerbations, coughing, and emesis. Rarely, isolated blunt trauma is associated with pneumomediastinum. That is the focus of today's talk. As part of a larger study, we posed the question, what is the current evaluation, management, and outcomes of isolated pneumomediastinum after a blunt traumatic injury in pediatric patients at a children's hospital? So we conducted a 5-year retrospective chart review of 10 MWPSC hospitals of patients ages 1 to 18 who presented with a primary diagnosis of pneumomediastinum after a blunt trauma. Patients were excluded if they had immunosuppression or had cancer. In total, 50 patients with isolated pneumomediastinum reported a preceding blunt trauma event. Half of the preceding events were sports-related injuries. The median age was 15 years, and 70% of patients were male. Of the 50 patients, 84% were initially seen at an outside hospital prior to transfer to a children's hospital. Of the referred children, 5 were directly admitted to a children's hospital, 24 were admitted after being evaluated in a children's ED, and 13 were discharged after being evaluated in a children's ED. Just 8 patients presented initially to the children's emergency departments. In total, 66% of patients were admitted to the children's hospital with a median length of stay of just 24 hours. The most common symptoms on presentation were pain, shortness of breath, and abnormal swallowing and voice. 40% had abnormal vital signs or leukocytosis on presentation, with the most common being tachypnea. No patient had hypoxia or hypotension. 80% of patients received a chest x-ray, with 48% getting a chest x-ray at the outside hospital and 62% receiving at least one chest x-ray at the children's hospital. 60% of patients received at least one CT chest, and 30% received a CT of the neck, of which most were performed at the referring center, although some patients had repeat imaging at the children's hospital. 36% received an esophagram, mostly at the children's hospital, and no esophageal leaks were identified. Based on clinical symptoms, 4 patients did undergo an evaluation of their airway with either an NPL or bronchoscopy. A small tracheal injury was identified on 1 intubated patient, which was managed non-operatively. There were no documented cases of recurrent pneumomediastinum, and no patient returned to the emergency department within 30 days. So in summary, most of our patients who present with isolated pneumomediastinum after a blunt trauma are discharged or briefly admitted, with few requiring a further workup. No child had an esophageal injury, and no child required a surgical intervention. Based on our findings, we recommend avoiding the routine use of esophograms in isolated pneumomediastinum after a blunt trauma. In the current era of telehealth and phone consults, where we liaise with our colleagues at adult trauma centers, these data can help us to reassure our referring institutions that in cases of isolated pneumomediastinum after blunt trauma, the well-appearing child can safely be monitored prior to discharge without need for a transfer to a children's hospital. Finally, pediatric hospitals should work with their referring hospitals to minimize the use of CTs in imaging of blunt trauma, with the remainder of the radiologic workup driven by the presentation and exam to avoid unnecessary radiation. Thank you.
Great job. Now open for questions.
Laura Goodman, Chalk Children's. Thank you so much for an excellent presentation. I would really love to see more of this work, but I think importantly, it's not really a question, but I guess how would you encourage that outreach? And I want to make a plug for the Access to Surgery for Kids Committee here at APSA. We have a breakout this afternoon to talk about the best care for the rural child. Not just your presentation now, but 2 of the previous ones as well point out the importance that we all have as pediatric surgeons in liaising with our adult colleagues and making sure that we really are advocating for those kids in centers where they don't have a pediatric surgeon, whether those are rural centers or adult trauma centers. So thank you, and yeah, I'd love your suggestions on how to increase those connections.
Thank you so much for your comment. I think it's really important how we work with our rural hospitals and our hospitals that are caring for adult patients and some children. At our institution, we make a point of contacting all referring hospitals to let them know the outcomes of the trauma case and give them recommendations for the future in regards to how their evaluation could be improved and how their care could be improved. And we frame it around improvement, not on the things that they did wrong. And I think it's really important to give it that positive light of we're all here to care for the patient, and we want to help you do even better. You did great. You got the child to us where we could do more care. Let's make it even better next time.
And we have a question from the chat.
So what do you think was the source of the pneumomediastinum if it was not an esophageal leak?
So in these cases, we do see, I'm going to give a sneak peek of the manuscript I'm writing. There is an exceedingly low rate of esophageal leak in pneumomediastinum. And so in these cases, it may just be that a small bleb popped in the lung or some other small thing that caused pneumomediastinum and not a pneumothorax, because these kids mostly don't have pneumothoraces either. But nothing is significant enough that a lasting injury is seen on any imaging study. So even if there is some injury, it's so small that it immediately is healing.
Thank you. Dr. Russell?
Dr. Hartman, awesome presentation. I'm going to go implement this next week.
I love it.
But and I may have missed it, so I apologize. Is there a group that we do need to get an esophagram? Did you identify anybody that I need to red flag it?
So in the larger group, so not within the trauma patients, we really didn't see any within our trauma patients. In the larger group, what we eventually determined was that the patients who have abnormal vital signs or leukocytosis on presentation should be evaluated further by a pediatric surgeon, and then based on that evaluation, we may simply just need to monitor the patient more, treat their pain and their symptoms and see if they improve, or some of those patients who aren't improving or who look unwell are ones that we're going to think about an esophagram. The 2 esophageal leaks in the larger cohort are both young children who looked very sick on presentation. They're not your well-appearing child.
Right. Thank you. Great talk.
Yeah.
All right, our next talk is, does time to operating room affect outcomes after pediatric blunt hollow viscous injury, a TQIP analysis? Our speaker will be Dr. William Johnston from Children's Hospital of Philadelphia.
Thank you for the opportunity to present here today. We have no relevant disclosures. Blunt hollow viscous injury is, of course, a relatively rare and somewhat difficult to diagnose condition. In contrast to solid organ injuries, for example, that have characteristic laboratory and imaging findings, the findings associated with hollow viscous injury can often be far more subtle. This can often lead to a relative delay in diagnosis and ultimate treatment. The studies that have looked at whether that delay in treatment actually impacts outcomes have been relatively limited thus far by smaller sample sizes, given the rarity of the condition. We sought to fill this gap by actually performing an analysis of a large national database to provide greater statistical certainty as to figure out why these patients are undergoing delayed operations and to what degree does it actually matter as long as they at some point actually receive the operation. As for our study, we queried the TQIP database over a 5-year period. We looked at patients aged less than 18 who had operations of the stomach, small or large intestine, and rectum after blunt trauma. We excluded patients, importantly, with solid organ injury, injury codes, as well as operations for solid organ injuries and thoracic operations. We did not exclude, patients that had chest tubes, patients that had orthopedic operations or neurosurgical operations. Overall, this criteria was trying to balance actually isolating the impact of the hollow viscous injury on the abdomen while still maintaining a realistic cohort of patients that actually tends to present with hollow viscous injury. Once we'd identified patients, we grouped them by time from arrival in the ED to transfer to the operating room in a manner that was intended to reflect acute transfer to the operating room, subacute the same day transfer, transfer the next day, and then ultimately what we defined as a delayed operation, an operation greater than 24 hours after arrival to the emergency department. You can see in our final inclusion criteria, we identified about 1,700 patients with what we described as isolated hollow viscous injury, of which 145 ultimately underwent a delayed intervention. As for the actual risk factors for undergoing a delayed operation, we found that those patients with a delayed operation tended to have higher ISS scores, higher AIS scores of various body compartments. They were more likely to undergo orthopedic interventions, and they were also slightly less likely to have an actual full thickness injury of the bowel, overall indicating with the injury scores a higher burden of injury for those with delayed operations. As for whether this actually mattered in terms of outcomes, overall, those with delayed operations did tend to have greater hospital length of stays. They were in the ICU for longer. They were more likely to be on the ventilator, to receive a blood transfusion. Overall, they had just a higher burden of hospital care in addition to their higher injury scores. But despite this, there was no difference between groups in terms of deep or organ space infections, in terms of sepsis, and importantly, in mortality as well. In fact, all of the mortality actually occurred within the first 12 hours of admission, indicating that if patients were likely to survive their acute period of hospitalization, they probably survived their entire hospitalization. We also looked at a subgroup of patients, I can advance here, of patients with full thickness injury, trying to isolate at least some patients who probably had succus in their belly at some point, and the story was essentially the same. Patients with delayed operations tended to have higher injury scores. They were more likely to undergo an orthopedic operation. They tended to be in the hospital longer, in the ICU for longer, more likely to require a ventilator. Overall, they were sicker patients that required a greater degree of hospital care. But despite that, the actual infectious outcomes, deep organ space infections, measures of sepsis, and mortality were not different based on time to the operating room. And again, all of the mortality occurred early in their admission. Overall, our conclusions from this is that the delayed treatment of hollow viscous injury is typically associated with an overall greater burden of injury. That probably indicates distracting injuries or other injuries that need to be addressed. But despite that, as long as the patient does ultimately receive the treatment for hollow viscous injury, it seems like the more bowel-specific morbidity and mortality isn't actually different between groups. That, of course, does not imply that prompt treatment of hollow viscous injury isn't important, but it does seem that the physiologic reserve of pediatric patients is perhaps better able to delay the onset of systemic infection than in adults. And while we didn't directly analyze this point based on our exclusion criteria, it is probable that patients who are being managed non-operatively for solid organ injury and are subsequently discovered to have a hollow viscous injury probably aren't harmed by that time of non-operative management. Overall, our clinical takeaway is that when there is still a clinically equivocal picture, providers don't need to be rushing to the operating room just based on analysis of the time, but judicious serial examinations are probably still safe in a monitored setting. Some of the natural limitations of using a large database are listed below, and I'm happy to answer any questions. Thank you.
Open for questions?
Hey, that's really nice work, Shannon Castle, Valley Children's. Do you know how many there were with solid organ injuries before you decided to exclude them? Because I think you spoke to it, it's all, those are the ones that are hard, right? You're like, are you hurting because you have blood in your belly or another reason?
We excluded about 700 patients based on the presence of solid organ injury. I think ultimately we decided to, we thought it might be better to analyze as a separate study. With this one, we were really trying to isolate what is the hollow viscous injury doing to the abdomen. We thought it difficult if we were also looking at patients that still had solid organ injury. If they had an infection, for example, would that be due to the hollow viscous injury, or is that due to perhaps an infected hematoma associated with the liver? It's, of course, a question we're looking forward to answering, but we ultimately decided was a bit outside of the scope of what we were trying to accomplish here.
So my second question too is, in light of this, when the college makes you flag delayed laparotomy, right? And my PI nurse is like, oh, what about this? And I was like, well, I think this was appropriate when I was looking at those. Do you think that there should be nuances then in how they flag those?
I think naturally. I think it's important to note just when it, for this, I think what we're trying to say is there's not really an actual important time cutoff to describe for delayed laparotomy. I think it could actually force providers to perform an operation sooner than necessary clinically indicated. I think for hollow viscous injury, it's much more dependent on the actual exam of the patient. And I think you're right that that nuance is very important, and that nuance is really, it's the most important factor for actually when the patient should go to the operating room, rather than we need to make a decision by 12 or 24 hours. That decision should really be made based on their actual clinical presentation.
Nice work. Thank you.
Thank you.
Nice work, Jonathan Kohler, UC Davis, Sacramento. I guess my question is, why stop at 48 hours? Because this,
yeah, absolutely. It was the concern was that because this is a national database, we just don't have the granular information, and I was very concerned there would be confounding factors we simply weren't addressing after that. I thought that 24 to 40 hours is pretty clearly a relatively delayed intervention. There's probably not a ton of confounding factors that we aren't accounting for, but because we don't have that granular database, I was concerned that if we just opened it up for indefinitely afterwards, there would potentially be other things that we just weren't seeing in the data.
Yeah, I mean, where I've seen this be a problem is, in kids who are 4, 5, 6 days out,
really? Yeah.
and are being, their unwillingness to eat is being attributed to other things, and I think you could look at this and see effects much further out than 48 hours. That's still, in my mind, fairly acute.
I would think so, certainly. I thought that would probably be almost best as a single or multi-institutional study where you actually have the provider decision-making. You can look at the progress notes and understand why it was delayed. I thought that looking at the trade-off of looking at the national databases, we just wouldn't be able to confidently say that.
Thank you.
Thank you.
Our next talk is low risk of clinically important traumatic brain injury in children who tumble downstairs, presented by Dr. Donna Cow from Northwell Health.
Good afternoon, everyone. My name is Donna. I'm a resident at Northwell Health, currently completing a research fellowship at Boston Children's. Thank you so much for the opportunity to present our work today. We have no disclosures. Falls are a common cause of head injury in children, with over 2,300 head injuries estimated to result from falls annually. Pediatric head injuries can result in traumatic brain injury, which can have devastating outcomes on development. Evaluation of TBI is typically made with head CTs. However, early exposure to ionizing radiation from CTs can cause lethal malignancies later in life. In 2009, PCARD developed predictive rules to stratify risk of clinically important TBI. Under this algorithm, falls from a height of greater than 3 feet are considered severe mechanisms of injury for children less than 2 years of age, while a fall from a height of greater than 5 feet is considered severe for older children. In the absence of other significant history and signs, a child with a severe mechanism is considered at intermediate risk of clinically important TBI, and a CT scan may be obtained at the discretion of their provider. In our practice, we noticed that patients who tumble downstairs were often managed as if they had a free fall from an equivalent height with an assumed step height of 12 inches. However, these patients were rarely diagnosed with clinically important TBI. The goal of this study is to assess the risk of clinically important TBI in pediatric patients who tumble downstairs and to improve application of the PCARN algorithm to better reflect actual risk in these patients. This was a dual-center retrospective chart review of pediatric patients treated for a tumble downstairs in the ED from January through December of 2021. Patients who met the following criteria were excluded from analysis. We adopted the PCARN CI-TBI definition as TBI resulting in death, neurosurgical intervention, intubation greater than 24 hours, or hospital admission of greater than or equal to 2 nights. We defined anatomic head injury as imaging-confirmed intracranial injury and or skull fracture. 3 PCARN TDS models were created and compared. TDS-12 assumes TDS is equivalent to a free fall from a 12-inch step height and is based on current observed clinical practices. TDS-8 similarly assumes TDS is equivalent to free fall, but with a more accurate 8-inch step height. TDS-0 does not consider tumbling downstairs to be equivalent to free fall and excludes it as a significant mechanism of injury. For each model, patients were calculated to be at high risk, intermediate risk, or at low risk of CI-TBI using PCARN criteria. A total of 344 patients were included in analysis. The average age in our cohort was 6.3 years, with 26% less than 2 years of age. 50% of our patients were male. Our patients fell an average of 7 steps, with 25% falling greater than or equal to 12 steps. 89% fell indoors, and wood was the most common step and landing material. 12 patients reported loss of consciousness, and 25 reported emesis prior to arriving in the ED. 3 patients had an observed GCS of less than 15 in the ED, and 6 patients were found to have altered mental status. Head CT was obtained in 34 patients. Of these, 2 were found to have anatomic head injury. No interventions were performed in these patients, and none were found to have clinically important TBI. 96% of our cohort was discharged from the ED, and 4% were admitted. 2 were admitted for TBI observation, and the remaining 11 were admitted for non-TBI reasons. Across all models, the same 7 patients were at high risk for clinically important TBI. Under TDS-12, 287 of the remaining patients were classified as intermediate risk, and 50 patients were considered low risk. Using the more accurate 8-inch step height in TDS-8 shifted 116 patients from the intermediate to low-risk category, resulting in 171 patients categorized as intermediate risk and 166 as low risk for clinically important TBI. If we instead use the TDS-0 model, 271 patients shifted from intermediate to low risk compared to TDS-12, leaving only 16 patients in the intermediate risk category and 321 in the low risk category overall. This means that if tumbling downstairs was excluded as a severe mechanism, as in TDS-0, only a small fraction of patients would be considered for a head CT. Again, across all models, no patients were identified with clinically important TBI in any risk category. In conclusion, there's a low risk of clinically important TBI in children after tumbling downstairs. TDS should not be considered equivalent to free fall during evaluation and treatment, and the number of steps alone should not be an indication for head CT in the absence of other significant signs and symptoms. Thank you very much for your time and your attention.
Thank you. We're now open for questions. So, quick question. How do you convey these important findings to parents that are anxious about going home because their baby fell down the stairs?
That's a really good question. I think a lot of parents, especially with the popularization of the tumbling downstairs trope in social media and in the news, are very worried, and understandably so, when their kids fall downstairs. I think it's important to educate them about the risk of malignancies and the harm of ionizing radiation, and really having a discussion with them to think about the pros and cons and coming to a balance of what the appropriate next clinical step should be. And I think having a lot of this data to show that really patients who tumble downstairs are not often found to have a clinically important traumatic brain injury would help alleviate their fears.
Great. Thank you.
Thank you very much.
Okay, next talk. Unnecessary scans lead to unnecessary rescans. An analysis of 464 children with mild head injury in a tertiary referral system. Speaker will be Dr. Rachel Rivero from Yale New Haven Health.
Hi, everyone. Thank you for the opportunity to present today. Our primary aim was to evaluate whether rescanning children with low or intermediate risk traumatic brain injuries led to changes in clinical management. This endeavor is important because although there are no established guidelines regarding interval imaging in children with low or intermediate risk TBIs. Although PECARN criteria have existed, the adherence is overall low, leading to increased unnecessary radiation exposure and hospital charges. In this trauma cohort, we show that it is safe to discharge patients without interval scans. I have no disclosures. Pediatric TBIs are common, with few resulting in hospitalization and even fewer resulting in death. CTs of the head are used initially to diagnose TBIs in children, but are associated with risk of secondary malignancies and contribute to significant costs to the U.S. healthcare system. In order to mitigate the risks of radiation and cost, PCARN guidelines were established to identify patients who are at increased likelihood of having clinically important TBIs and who might benefit from CT. Children with intermediate risk injuries could be scanned or observed, and children with low risk injuries should not be scanned. However, there is no formal consensus regarding how to proceed after a radiologic finding in low and intermediate risk injuries and the benefit of interval imaging. In order to evaluate whether interval imaging changed clinical practice, we performed a retrospective chart review looking at children under 16 years who presented with blunt traumatic head injury either primarily or as transfers to our institution. We then stratified children by age group and PCARN risk category. During the study period, a total of 1,136 children presented with low and intermediate risk TBIs. We stratified this cohort by age and by those who received a trauma consult or had a trauma activation. In both infants and toddlers or children, the majority had intermediate risk TBIs. A few were excluded from analysis due to high-risk criteria. In infants, none had a clinically important TBI, and in children, one patient had an epidural hematoma that required evacuation. We analyzed imaging findings and subsequent management in children with low and intermediate risk TBIs in both age groups. In infants with low-risk injuries, all underwent initial CT scan. Of these, 5 had an intracranial hemorrhage, 12 had a skull fracture, and 4 had both. 9 of these patients underwent an interval MRI, and only 1 had a radiologic change, which is defined as a bleed that was not previously seen on CT or an interval increase in the bleed. However, no children underwent neurosurgical intervention or changes in clinical management. In infants with intermediate risk injuries, the majority underwent an initial CT scan. 114 of these children had radiologic findings, and 71 underwent subsequent CT or MRI. Only 5 had radiologic changes. However, none had any clinical changes, and none had clinical changes or changes to their clinical management based on the changes in their radiologic findings. In toddlers or children with low-risk injuries, a little over half underwent initial CT scan. 11 had radiologic findings, and 9 of these patients underwent subsequent CT or MRI. 2 had radiologic changes. However, again, no children had clinical changes or underwent neurosurgical intervention based on the interval imaging findings. Finally, in toddlers or children with intermediate risk injuries, most underwent initial CT, 89 had radiologic findings, and like I mentioned previously, 1 child had an intracranial hemorrhage with midline shift and was taken to the operating room. However, this decision was made prior to interval imaging. 19 of these patients had radiologic changes on their subsequent imaging, but no decision to take the patients to the operating room was made based on these findings. In conclusion, over-imaging was common in our trauma cohort. Repeat imaging was also common in the low and intermediate risk patients. No low-risk patients underwent neurosurgical intervention or exhibited clinical changes, and no intermediate risk group patient exhibited clinical deterioration during the observational period. Repeat imaging at our institution did not change the clinical care pathway in any patient. In conclusion, interval scans do not change clinical management in low and intermediate risk TBIs. Children with low and intermediate risk injuries can be observed or discharged safely without need for transfer or repeat imaging. Clearly, at our institution, adherence to PCARN criteria, at least in the trauma cohort, is low, but we proved that it is safe to discharge patients with low and intermediate risk injuries without having to rescan patients. This is important because it leads to improved resource allocation to reduce the risk of secondary malignancies and hospital charges. Thank you to our pediatric surgery team and the pediatric surgery department at Yale. This couldn't have happened without you.
Open for questions.
I sat too far away to have so many opinions. Jonathan Cole, UC Davis. I have 2 questions. I guess the first is, like, this seems like an amazing opportunity for an effective de-implementation campaign of trying to get your place to just be guideline concordant.
Yes.
And then you point out that there are no good guidelines for peds. There are great guidelines for adults, which is the big criteria. And what steps do you think we could take to develop a good guideline to help us with children?
Yeah, so to answer your first comment, so this actually kickstarted a QI initiative at our institution. About 50% of these patients were actually transfers. And so we've implemented an EPIC, a pathway that guides clinicians to make the right decision with regards to even ordering initial CT on low and intermediate risk patients. To your second point, how do we create guidelines? I think this study was really great because we were able to obtain very granular data. However, it is very limited to our institution and also to just trauma patients. I think doing a larger scale study to further prove this will help make guidelines stronger to encourage both our pediatric surgery colleagues, ED colleagues, and neurosurgery colleagues that interval MRIs are not necessary in these low risk, intermediate risk kids.
Thank you.
And our last talk for this session is Pre-Hospital Tourniquet Usage in Adolescent and Pediatric Traumatic Hemorrhage, a national study, presented by Dr. Alice Martino from UC Irvine.
Thank you so much for the opportunity to present today. We have no disclosures. We did this research to evaluate the effectiveness of tourniquet placement by different providers in children. This is important because tourniquets are a critical intervention to control life-threatening bleeding in the pre-hospital setting. However, data regarding their use in children is limited. Hemorrhage is the leading cause of preventable death due to trauma, and 2,000 children die each year from preventable traumatic hemorrhage. Tourniquets are a critical intervention to control bleeding in the pre-hospital setting. However, data is limited on their use in children. Tourniquets have been shown to be efficacious in adults, both in the civilian and the military settings. The Stop the Bleed course has been instrumental in increasing the utilization of tourniquets by non-EMS personnel, notably bystanders and first responders like police and firefighters. Data is obviously limited in the pediatric cohort, especially in wartime settings, is the only thing we have at this moment. Adult-sized tourniquets have been used successfully in children of all ages, and their survival rates are very similar to adults. However, there are no large studies of tourniquets applied to children in civilian settings. Therefore, we sought to use a large pre-hospital database to evaluate the effectiveness of pre-hospital tourniquet application by different providers in children. We hypothesized that for pediatric patients with pre-hospital tourniquets, there would be similar rates of success regardless of the provider that placed the tourniquet, and that tourniquet placement would be associated with increased odds of acuity improvement. Acuity was determined by EMS personnel at the scene and then again at arrival to the treating facility in terms of hemodynamic, neurologic, and respiratory status. Critical acuity was defined as symptoms of a life-threatening illness or injury that had a high probability of mortality if untreated. Emergent symptoms were those that would progress in severity or result in complications with a high probability for morbidity if treatment was not begun. And non-emergent acuity was patients with symptoms that had a low probability of progression. We conducted a retrospective review of NEMSIS, which is the National EMS Information Systems Database, for patients ages 0 to 19 who had a tourniquet placed from 2017 to 2020. These tourniquets were applied by EMS, first responders, and bystanders. Bivariate analyses were used to determine differences between the groups, and a logistic regression model was used to predict change in acuity after the tourniquet was placed. Our primary outcomes were procedure success and the change in acuity from scene to hospital arrival. We identified a total of 301 patients whose median age was 17 and 86% were male. Patients were initially stratified by the time of tourniquet placement relative to the arrival of EMS transport. There was a difference between the providers who placed the tourniquet, with first responders and bystanders being more likely to place tourniquets prior to transport arrival. EMS still places the majority of tourniquets, and nearly all tourniquets placed after arrival of transport were done by EMS personnel. Tourniquet placement was overall very successful with a 97% success rate regardless of the time the tourniquet was placed. When examining patients based on the provider who placed the tourniquet, there were differences in the revised trauma score, or RTS, between these groups. RTS is a measure of injury severity based on Glasgow Coma Scale, systolic blood pressure, and respiratory rate. Patients with tourniquets that were placed by first responders had the highest average RTS and therefore had the most severe injuries, followed by those treated by EMS and then by bystanders. Acuity at EMS and ED arrival were significantly different between these groups. Patients with tourniquets placed prior to transport arrival were less commonly of critical acuity compared to those placed after transport arrival. Likewise, fewer patients with tourniquet placement before transport arrival had critical acuity on arrival to the treating facility than those with placement after. However, the change in acuity between groups was not different, with the majority having improved acuity after their tourniquet was placed. When we stratified by the provider placing the tourniquet, there was no difference in the change in acuity after tourniquet was placed, with more than half having improved acuity. All providers had a high rate of success, with nearly all tourniquets successfully placed on the first attempt. We then performed a logistic regression model that was used to identify factors predicting improved acuity in tourniquet placement with children whose initial acuity was deemed to be critical, after adjusting for patient and provider-related variables. RTS and tourniquet placement by bystanders and first responders was associated with an increased odds of improved acuity. In conclusion, we found that EMS, first responders, and bystanders have comparable rates of success when placing tourniquets in children. The majority of children with critical acuity had an improvement in their acuity score after the tourniquet was placed, regardless of who placed it. Placement by first responders and bystanders was associated with an increased odds of improved acuity on arrival to the treating facility compared with those placed by EMS. Future prospective research is needed to understand the in-hospital and long-term effects of pre-hospital tourniquet application in children, and additionally, strategies to optimize coordination among various pre-hospital providers should be explored, with the goal of providing timely pre-hospital care for children with exsanguinating extremity hemorrhage. Thank you, and I'll take any questions at this time.
Thank you. And we're open to questions.
Rome Ignacio, San Diego. I think this is the first pediatric-specific study. I know the military has done mixed adult and ped, so I congratulate you on this study. But can you give me a little bit more information? I don't know if you have it, but where did they get the tourniquets? What type of tourniquets were used? And the reason why I'm asking that question is there's some legislation by certain states, I'm one of them, California, that's looking at stop-the-bleed kits. It's a lot of money. And if it's not worth the investment of doing it, that's great. People are finding other things. But if it's worth the investment, this would be very powerful for those in advocacy. Thanks.
Yeah, that's a fantastic question. The NEMSIS database doesn't have any specific data about where these tourniquets are coming from. But just looking, the majority of these tourniquets are placed by EMS, and so they're adult-sized tourniquets that they have on the rig. And there have been studies that have shown that as long as you can get it tightened around the child's arm, doesn't matter how much extra fabric is hanging off, it will be effective. In terms of the bystanders, that would be a really interesting question to see, are these tourniquets that people have on with them because they attended a stop-the-bleed course, or are these tourniquets that are present, like AEDs would be present at, a sporting facility or a conference like this? That's a really interesting thought.
No, that's still a great message, because if you go to airports now, you have your AED and you have the stop-the-bleed kit. People are going to say, well, that's an adult size, I can't use it. But no, that's actually even just as good of a message too. Thanks.
Thank you.
Hi, Rami Jamshidi from Phoenix. As Dr. Ignacio said, thanks for looking into this, because there's a dearth of literature in general. We need to understand tourniquets better. I'm not personally familiar with this database that you dug into and employed. Was there any element in there that you could use to look at necessity of the tourniquet after the fact? What was the assessment on arrival at the hospital? Because we are getting information that tourniquet, I think many of us are seeing it anecdotally, but it's coming out and will be published as well. The Ukraine experience, there are people losing limbs over tourniquets that were subsequently judged to probably not have been necessary in the first place.
Yeah, I think that's a really interesting point. Unfortunately, this is an exclusively pre-hospital database, so it's from when EMS initially evaluates the patient up until they arrive at the ED. And a lot of the studies in adults that look at that exact question look at what the ED and surgical providers evaluated when they took the tourniquet down after the patient has arrived. So the database we used doesn't have that information, but I think it's a really important thought is if we're putting these tourniquets on, are they indicated, and what sort of complications are we seeing in kids who had tourniquets placed that weren't necessary or improperly placed?
Yeah. If you'll indulge me, it ties back to Dr. Ignacio's point about, we've been really effective in spreading the word and equipping people with the knowledge and the physical equipment to apply tourniquets all over the place, which is a sad reality of our modern era, right? The battlefield has come into the public sphere. But is it, and I'm probably something like Sniper from the ACS is going to take me out for saying this, but are we directing our efforts in the right place or not? I'll say it. Yeah. Thank you.
Thank you.
Thank you. Good job.